Coming up on Why Should I Trust You? It's a heartbreaking story triggering discourse around the country. The murder trial of Lindsay Clancy, the mother who killed her 3 young children. Her defense? That she was suffering from postpartum psychosis, a mental breakdown that made her unaware of her actions, and that a medical system prescribed her drug after drug without getting to the root problem. The prosecution in this case says no. These were acts of a mother who, while depressed, was very much in control of her actions and able to know right from wrong. And then there's the way the nation is responding. The story of a mom killing her children has landed in an America already divided over the medical system, health, women's health in particular, and personal responsibility. One side says the tragedy has highlighted how our systems and society fail mothers who cope with mental illnesses and depression, and yes, the rare psychotic breakdown in the shadows. The other side says this is about a killer, and while more should be done for the mental health of moms, somehow explaining away what this mother did is a sign of how off track our culture has become, placing the actions of a, yes, even suffering adult over the murder of her 3 children. But has the Lindsay Clancy trial quickly become a proxy for something bigger? Arguments about psychiatry and medication, motherhood and mental illness, personal responsibility, and about whether our medical system is fundamentally failing the people who depend on it. In choosing sides, are we at risk of turning one horrific case into evidence for conclusions that go far beyond what this particular tragedy can actually tell us? We're joined by 3 medical experts today to talk about all this. Lots to get to, so let's get started. Hey, welcome everyone. So the Lindsay Clancy story, it's been consuming so much attention this summer, and we've obviously seen all the headlines in social media. We have this little Signal group that we have done as a show, and we have listeners on it. We have some former guests on it, and it's really sparked a conversation on that chat group. And people are watching the trial on YouTube. Likely millions of moms are discussing it as well. I'll say, as a mom, it hits home for me. But I'm gonna be honest. There's a part of me that doesn't want to engage with it. It's just so unbearably sad. But to see that this is impacting the ecosystem that we're focused on, that we talk about every week, trust of the medical system, of expertise, of medicine, it just seems like the story is just kind of sitting on a few different fault lines, which makes it really ripe for the sort of why should I trust you treatment. So today we're going to be joined by 2 psychiatrists, doctors Julia Riddle and Brian Shapiro. One of them specializes in maternal care, and the other one specializes in tapering, particularly women off of antidepressants. And we're also going to be joined by Dr. Ann Zink, who is an ER doctor and a public health leader. We're taping this on Tuesday, August 25th. A lot could happen as this trial winds down before we drop this on Thursday. But first, who are we? I'm Brinda Adhikari.
I'm Tom Johnson.
Maggie Bartlett.
And I'm Dr. Mark Abdelmalek.
And this is Why Should I Trust You, a weekly podcast exploring the breakdown in trust around mainstream science, medicine, public health, AI. And through weekly conversations, we feature diverse perspectives and discuss what, if anything, we can do about it.
So a bit of housekeeping from our end, newsflash. It takes resources to make the show. So to that end, starting today and occasionally going forward, you're going to hear us starting to acknowledge our financial supporters of this program. So to be clear, that doesn't change what we do. We are, as always, fully in control of the editorial for this program. And actually, that's something that's really exciting for us with some of these partners that we're working with. They trust us. So we just wanted to give you a heads up. And we also recognize that this may surface some questions for you. So do hit us up at questions@whyshoulditrustyou.net. Okay, so Mark, you wanted to say some things ahead of today's episode, given what it is that we're discussing.
Yeah, a quick reminder, we're covering this topic because of its national interest. And of course, do not take anything you hear today as your own medical advice. As always, consult your own doctor for these kinds of important decisions. Now, because today's episode does touch on postpartum mental health, we want to speak directly to the new parents listening and to anyone really caring for someone who has recently had a baby. We've all heard it takes a village. If you are struggling right now, there is help made specifically for you. You can reach the Postpartum Support International line by calling or texting 1-833-943-5746. That's also known as 1-833 and then the letters TLC MAMA, MAMA. And finally, if you or someone you know is struggling with thoughts of suicide, there is free confidential help available anytime, 24 hours a day, 7 days a week through the 988 Suicide and Crisis Lifeline. So you can call or text 988 or chat at 988lifeline.org.
Okay, thanks for that, Mark. And we'll put all those resources that Mark mentioned in the show notes. So, Tom, before we bring our guests on, help us get a handle on the story.
Yeah, so let's just talk some basics. Lindsay Clancy, 36 years old. She was married to Patrick Clancy. They lived in Duxbury, Massachusetts, and together had 3 children, ages 5, 3, and 8 months. On January 24th, 2023, Lindsay Clancy killed her 3 children. That's not in dispute. She does not dispute that she killed her children. What is in dispute, and it's at the heart of this case, is whether she was suffering from postpartum psychosis, which is an extreme mental illness at the time of the murders. Postpartum psychosis is rare. It's diagnosed in an estimated 1 to 2 out of every 1,000 births. It can happen rapidly after childbirth with hallucinations, delusions, and severe mood disturbance, and it always requires urgent medical care. It can cause a total break from reality. In essence, Lindsay Clancy's defense has argued that she suffered from postpartum psychosis and bipolar disorder, and she has pleaded not guilty based on a lack of criminal responsibility. The prosecution is arguing that while she suffered mental illness, she was not psychotic when she committed the crimes. The prosecutors asserted in court that murdering her children was a, quote, calculated decision, telling jurors that Lindsay Clancy, quote, was coldly efficient when she executed them, and that she could be held criminally liable. In separate lawsuits, Lindsay and her now ex-husband, Patrick Clancy, alleged that various medical providers failed her. The trial has focused on 5 months at the end of 2022 and the beginning of 2023. Lindsay Clancy was out on maternity leave from her work as a labor and delivery nurse at Massachusetts General Hospital following the birth of her 3rd child. And in the summer of 2022, she was reportedly doing well. But by the fall, things changed. Her husband described Lindsay's anxiety as rising. He said she worried about returning to work. Lindsay began seeing medical professionals for help. She reportedly becomes deeply depressed. She cannot sleep, eventually reporting suicidal ideation and thoughts about harming her children. From September to January, when the killings occur, she was seen by at least 4 providers, including a psychiatrist, 2 nurse practitioners, plus emergency room doctors and inpatient staff across 3 different hospitals. She saw her psychiatrist 14 times, all via telemedicine, over that same time period. In total, she was prescribed 13 different medications, including antidepressants, antipsychotics, and sedatives. On that list were 2 SSRIs. These are, of course, selective serotonin reuptake inhibitors. These are commonly prescribed types of medication used to treat depression, panic, and anxiety disorders. In December alone, Clancy reportedly made 8 doctor's visits. There was clearly a lot being done for her. She was receiving medicines, but did she receive the right care? Is this a case where there are just limits to what medical professionals can do for someone? Or was this actually not about medicine at all, and rather, as difficult as it is to process, was this about someone who just chose to kill her children?
So, Tom, let's dig a little deeper into what's come out at trial. There's so much that's not clear, but what is clearly unfolding is a story about a system straining to keep up with a deteriorating patient. Now, that number you talked about, Tom, the number of prescriptions he was prescribed, that seems to be a sticking point for so many people. We hear the number over and over, 13 different drugs and 30 different prescriptions. When you read the list, it's anxiolytics, so anxiety medicines, it's antipsychotics, it's antidepressants. And Tom, you mentioned the number, and you said was in total. There's also another factor here that we aren't sure exactly what she was taking, and there's nothing that suggests that she was taking all 13 medications all at once. Now, there is something that does show up, and people who take care of patients like this are very familiar and can recognize it. It's a pattern of repeated changes. You have a patient who's struggling. We have in our toolbox lots of medications. We turn up doses, we turn down doses, we stop drugs, we restart medications, we swap in medications. And sometimes that's necessary to figure out how a patient gets what they need. But it's also a red flag because if you're prescribing medications and you're not seeing the results that you expect, sometimes that really raises a flag to consider or reconsider the underlying diagnosis. Now, much of Lindsay's care happened through a patient portal. So she logged in, she was texting, she was communicating with her psychiatric nurse practitioners, and she was actually pretty engaged in this. She sought care many times. She was a forthcoming patient. She flagged side effects. She raised her own concerns. She asked for medication changes. At points, she writes down things that really should raise flags. There are things that she said that could actually stop a clinician in their tracks. She describes having very intrusive thoughts I never had before. Those intrusive thoughts are a flag and a concern for a specific thing. These are unwanted, distressing thoughts that find their way into your mind, and they do so almost against your will. And the fact that she said something particular I never had before, that's also clinically significant. It signals that it's something new, it's sudden, it's out of character, and it's the kind of change or signal or clue that warrants close attention. She also raised a concern that many patients talk about when you're prescribing them medications, and that's about becoming addicted. Now, she raised these concerns, but she was also reassured. Her providers talked about the intrusive thoughts sometimes being something that can occur from postpartum depression. And they also suggested to her that she hadn't been on the medications long enough for her to develop an addiction. Now, Tom talked about this period of 5 months right before the tragic events happened. So just after Thanksgiving, Lindsay was started on Seroquel. This is sort of a game-changing prescription because it's an actual antipsychotic. Now, it is FDA approved for schizophrenia. It's approved for bipolar disorder. And it's also as an add-on treatment for major depression. So just because it's an antipsychotic doesn't mean that's why they prescribed it for the psychosis. Now, Seroquel's prescribing information emphasizes that once you cross this threshold and give this kind of medication, you need really important monitoring for worsening of the situation. You can have suicidality, you can have unusual behavior changes, and sometimes these things happen right around when you're changing your dose, whether that change is going up or going down. And those kinds of warnings are tragically close to what her ex-husband described. Now, Patrick Clancy testified that after she started Seroquel, what he called a, quote, big spiral for Lindsay began. He talks about worsening depression, weight loss, suicidal thoughts, and most alarmingly, thoughts about her children being harmed. Now, he testified that he directly asked her, quote, do you feel like you need to be kept away from them? And that she answered no, and that he did not believe that she had any intention of acting on those thoughts. Now, in December, the nurse practitioner raised a possibility that Lindsay could be bipolar, which again, like Tom mentioned, becomes a key question. By mid-December, Clancy went to the ER after experiencing persistent suicidal thoughts, but she declined inpatient care. Then she wanted to get into a postpartum program in Rhode Island, but after being evaluated, she did not remain in that program. And then a provider there recommended that she taper off of that antipsychotic we talked about, Seroquel. Now, her nurse practitioner was uneasy about that advice, but helped her taper anyway and testified that she hadn't realized Clancy was still actively seeing her psychiatrist the whole time or what that psychiatrist had prescribed. So again, she had a whole list of prescriptions, but sometimes people don't take the prescriptions as prescribed. Now, it is worth noting not every provider is criticized here. Clancy's own defense attorney credited one nurse practitioner with going out of her way for Lindsay.
Yeah, then this tragic timeline marches forward. On New Year's Day, Clancy admitted herself into an inpatient psychiatric care at a hospital. And doctors there diagnosed her with severe depression without psychotic features. But they said they were still actively working on her case, checking for bipolar disorder. When she arrived, Clancy told the hospital she wasn't feeling depressed or suicidal, despite in December reporting having suicidal and intrusive thoughts. She spent 5 days in the facility. She left after asking to return to her family. Then on January 24th, she asked her husband to go out and pick up medicine for their children and dinner. Lindsay Clancy then strangled her 3 children before leaping out of their second-floor window, which left her paralyzed from the waist down. Her defense team has tried to establish that she had bipolar disorder and postpartum psychosis at the time of the killings. Their expert witness examined Lindsay 4 months after the killings. He said she suffered from both these conditions and was not in control of her actions. The defense says that she had delusional belief and heard a voice that told her to kill her children, quote, so you can kill yourself. Under cross-examination, the defense's expert acknowledged Clancy had not told her doctors about thoughts of harming her children. The prosecution's expert witness examined her 2 years after the killings and concluded that she suffered, at the time of the killings, from major depression, but not psychosis. In other words, depressed, but in control of her actions and able to tell right from wrong.
Yeah, and just a couple important notes here. We spoke about her being prescribed SSRIs, and these are standard first-line medications with a strong track record for easing depression and anxiety, usually tolerated with mild side effects. So the FDA does require its strictest black box warning on all antidepressants. And that warning covers suicidality risks in patients up to the age of 24 years old, but not homicide risks, right? So no psychiatric medication currently carries any sort of equivalent warning for violent or homicidal thoughts, but they do list that they can contribute to agitation, mania, or psychiatric changes in a patient, especially around dose changes. And another note is that the defense team stated that someone who is bipolar generally shouldn't be prescribed SSRIs by themselves. And that's their real clinical concern that's being raised, is that if you give an SSRI without a mood stabilizer to somebody who has unrecognized bipolar, that can actually trigger a manic or mixed episode. And again, I think we need to note that Lindsay was not diagnosed as bipolar before the killings. And it was the post-killings bipolar diagnosis that came from an expert for the defense, while the expert for the prosecution disagreed. And if you kind of zoom out from all of this, I think that we see the landscape in maternal mental health as an important backbone for this. So more than a third of counties are these maternity care deserts. And that means they don't have an OB or even a birthing facility. And that 1 in 4 women from rural locations in America end up traveling over 30 miles to give birth. And the ER ends up being their backstop if they can't make it to one of those facilities. And if we look at mental health for new moms, 45 states lack even one maternal mental health inpatient or residential treatment program. And when you look at the fact that 1 in 5 pregnant or postpartum women in the US experience a maternal mental health condition, roughly 75% of women are left untreated and undiagnosed.
Boy, this is such a tragic story, and thank you for all that background. So when we come back in just a moment, we're going to turn to some experts to help us unpack how this trial is impacting America's trust in the medical system and perhaps in the legal system too. We'll be right back.
Support for this podcast comes in part from the Robert Wood Johnson Foundation, a leading national philanthropy dedicated to transforming health in our lifetime and building a future where health is no longer a privilege, but a right.
Okay, welcome back. And we are really thrilled to welcome our guests here. So first up, we want to welcome Dr. Julia Riddle. She is a reproductive psychiatrist and researcher focused on reproductive mental health. She's an assistant professor at the University of North Carolina Center for Women's Mood Disorders, where she runs a clinic for patients. She also helps train clinicians nationally on recognizing the kind of mental health illness we're discussing today. Dr. Riddle, welcome.
Thank you so much, Brinda.
Also with us is Dr. Brian Shapiro. Dr. Shapiro is a board-certified psychiatrist based in Orange County, California. He serves at UC Irvine Medical Center, where he treats outpatients and trains primary care physicians and nurse practitioners on prescribing psychiatric medications. And for full transparency, he is the medical director at Outro, a company focused on helping patients safely taper off antidepressants. Dr. Shapiro, welcome to the show.
Thanks, Brinda.
And finally, we're glad to welcome back to the show Dr. Ann Zink. She's a friend of the pod, has been on several times. Dr. Zink is an emergency medicine physician and public health leader who served as chief medical officer for the state of Alaska before and during the pandemic. She was also the president of the Association of State and Territorial Health Officials, which represents public health leaders. She's now a senior fellow at the Yale School of Public Health. Dr. Ann Zink, welcome back.
Great to see you all again.
So, Dr. Riddle, let me start with you. We've walked through some of the themes that have emerged from this trial. And beyond the tragedy of this, I want to give each of you the opportunity to kind of step back and talk about what you, as a medical professional, as a teacher in some cases, what you feel that this trial is surfacing for the public, whether it's positive or negative.
Yeah, thank you for that question. It brings up a lot. And I think one of the biggest things it brings up is that we're not doing enough. We owe women and families so much more. I also sit on the board for the National Curriculum in Reproductive Psychiatry. So I think about this sort of soup to nuts. We need better training at every level. Reproductive psychiatry is not part of any required training in psychiatry, in OBGYN, in NP training, in PA training, in therapy training, in psychology training. So it's not happening. We don't have investments in our research. So it wasn't until 1993 that the NIH included women in clinical studies. And it was 10 years ago in 2016 that sex was considered a biological variable in molecular research. So we're holding ourselves, the media right now is holding everyone to a standard that we didn't invest in before now looking at it. And then beyond that, we have so many holes in our pipeline, right? We have so many opportunities that even when the system is functioning well, where women and families are getting dropped off, that has to do with how the system is developed, that has to do with not having paid maternity and paternity leave, not having enough time for prevention, not investing in preventative measures, and then not having enough time in the postpartum for women to be seen and captured. So it brings up so many things in my personal opinion. And then on top of that is stigma. And then the standard by which we seem to hold women to at all times. And so we see it all in this case, and we see it all in the media coverage. And it's like always, it's impossible to introduce nuance into these conversations, especially when these outcomes are so dire and horrible and truly the thing that we all fear the absolute most, I think, individually, as women, as mothers, as parents, and as clinicians. They're the scariest thing we can think of.
Dr. Zink, I want to bring you in. When you hear the phrase "we're not doing enough," and I've heard this now said in multiple contexts, the idea that maybe the medical system or society as a whole, we're not doing enough, it kind of bumps up against the idea of personal responsibility, and that ultimately this was a woman who took it upon herself to kill her children. At what point do you still think that this is a story about we're not doing enough?
Yeah, I think I always go back to patients and people at the beginning and the end of any story. And at the end of the day, 3 small children are dead. A family is devastated. Community is broken. And I think we all see that, hear that, and feel that, and want it to be different, right? We want providers to be different. We want the system to be different. I also want our communities to be different. I think so often we put all of society's ills on healthcare. How come you can't do this? And not even on a health system. We put it on healthcare individual people. I watch the psychiatrists up there just being questioned and what's being asked of them. And all I keep thinking in the back of my mind is America, do better. Let's find better ways to have prenatal care, postnatal care, be able to get moms sleep. I remember how hard that was having 2 small children. And yeah, we do need to do better as healthcare providers, as trainees. As an ER physician, we've had a 90% decrease in psychiatric beds in this country since 1955. My emergency department is boarding with patients desperate for help every single day. And if they don't have an immediate harm to themselves or others, I can't keep them against their will. We've really moved to this incredibly liberal side. If someone says they want to go home, and I look at someone like her who has resources, is connected, says that they want to go home, isn't saying that they're going to hurt themselves or anyone else, I'm essentially kidnapping them in the emergency department if I keep them against their will. And so I have to discharge them. And I think about the ways that our systems don't connect, how hard it is to find out outpatient records. And psychiatric records are way more protected for privacy reasons than even other health records. So it becomes nearly impossible
to see, if Julia had a note and I had a patient with her, it'd be like impossible for me to see it, to be able to feel like what's happening, let alone to be able to figure out if there's a call. So we see this all put on trial. But at the end of the day, like, healthcare workers are people who care deeply about their patients and about trying to do their best in an incredibly broken system, not only within healthcare, but within our country as a whole. So I think that that's what brings up in this case for me.
Dr. Shapiro, I want to bring you into this, and then we'll open it up to everyone. Lindsay Clancy seems to be an example of somebody who did get a lot of support. She was on, I think at one point we had said something like 13 different medications, maybe not all at the same time. She had been hospitalized several times. She'd been seeing clinicians. Is this an example to you of over or under support?
Yes. So I think Lindsay Clancy, in reviewing her case, she appeared to get the standard of care. And I think folks watching this case, I think will have serious concerns about the standard of care if that is getting prescribed, too much medication. I think at one point she was prescribed Ambien, Klonopin, and mirtazapine all on the same day. So I think it's sometimes the word care can become a euphemism for pills. And I think we need to take a look more comprehensively at the patient's care plan and reflect on the fact that medications might not be the answer in many of these situations, especially when there's a clear indication that she was feeling worse as she was prescribed increasingly intense, serious, hardcore medications such as Seroquel.
So Julia, like just listening to you guys talking, 3 different care providers here on our podcast, it seems like we're expecting a lot from the care that we get. And there's such a critical eye after the fact, especially as it's like refracted through the media at a trial as to what, each step along the way of this like 5-month period before the tragedy. When you step back and look at this and the headlines that are coming out of this trial, it's the kinds of care that she was given. Are you taken aback by the amount of medicine she was given, or do you recognize that as this is the process of trying to give a patient and get a patient what they need, and there's trial and error, and we're missing nuance here because maybe certain medicines were, turned down while others were being experimented to turn on to see if it would work for her? Like, what do you see in the subject of the medicines that Clancy was given?
Yeah, so I want to be very careful. I am not a forensic psychiatrist. I have not evaluated her records, and I am not here to actually play judge or jury on a legal case that I am not a part of. So I want to be very, very respectful of that, because I do think that psychiatric illnesses and particularly postpartum psychosis, they change so much. Strictly the nature of the illness is that it is waxing and waning. And so and I actually really agree with Dr. Zink's comment here that like we rely on the community to tell us this is not quite right, because we have built a healthcare system to serve a population that is 1/3 the size of our population. And so when patients come in, there's not a ton of time to sit with them. We wish we could, but we've tripled the population with the same workforce and infrastructure. And what can happen is when a patient is very sick, and a patient with postpartum psychosis. Again, I don't know. I'm not here to say what Lindsay Clancy had. I'm here to talk about postpartum psychosis. That waxing and waning quality, what does that mean? That means they can be completely themselves, like in delirium. They can be oriented. They can know what's up. They know what's going on. Minutes later, hours later, they can flip into psychotic thinking. And so if you catch a woman or you kind of bring about enough structure around her that she says, okay, I gotta kind of pull it together and I gotta pull from my reserves, she'll be able to say, no, I'm just anxious and I haven't been sleeping well. She'll be able to say that to you, and we see it all the time. Hours later, when her reserves are lower, for whatever reason, we don't know because we don't have enough research, those psychotic symptoms will come in. So I really want to play to the idea that we rely a lot on people's community, like you said, on their spouses, on the people that know them. And I've had patients reach out to me and say, my parents were able to identify postpartum psychosis because they look at that mother and they say, that's not you. Something is not right. But in those 10 minutes or those 20 minutes or those 40 minutes that you spend with them, sometimes they can contain it. And you have to be so skilled because we don't have the biological measures. We don't have an X-ray, right? We are relying so much on patient report and what they will share with us and our deep, deep training. but it is very, very hard. So it's very hard to judge what other people are doing in this way when they're not my patient.
And you wanted to add something.
Yeah, no, I really agree with Dr. Riddle, but I want to emphasize, like, I love this podcast in many ways on why should I trust you? But in some ways, there's the you in there. There's like the individual person, but oftentimes we're talking about systems. And I've been thinking more and more about, like, instead of like, why should I trust you? Like, how can I help you help me? And so I think, like, in hearing Dr. Riddle, like, how can families help us help them? Bringing in a med list, being really clear about what's needed or not needed. Like, we are working in a really broken system, trying to support patients, making sure people's wishes are known. If it's something simple like DNR or DNI, if they don't want to be resuscitated, that's like incredibly hard to actually be able to find within the system. And then also, like, engaging with the system to make it better. And so I think that there are so many systems failures with this case in the ways that information is shared, the way that, healthcare follow-up happens, the way that, again, as I was talking earlier about, like, society as a whole, like, we need to partner with moms across the country, and we need to partner with providers across the country to help us help you, so that we aren't blaming each other, but instead we're all working on these systems. I mean, labor and delivery and psychiatry are two loss leaders for healthcare. We're seeing, closing across the country, labor and delivery, postpartum support, psychiatry, and her story hits both of those things in so many ways, let alone the research and additional information. And we have to find a different way to fund those, or we're failing our families.
And I want to texture just one more thing onto that. I also sit on our access line, right? So a lot of states have developed these physician access lines where you can call a professional. So a little bit like what Postpartum International has, but each state has their own funded one. The reason I say that is one of the most requested things from us is partner support resources, because it's the mother, it's the baby, but we forget that the partner is often just as anxious, just as overwhelmed, and they don't know what's not normal, particularly with a first child. They might say, she hasn't wanted to have visitors, but maybe that's normal. I don't know. I've never been here before. So, some people ask me, why do you need a specialty in reproductive psychiatry? And it's like, well, I think a lot of people could do it with additional training, but it's because I'm constantly sitting with this same population. So I see the differences, right? It's so easy to normalize this stuff. So easy. It's so easy to say, oh, you're just a caring mother. That's why you're so anxious. You're just overwhelmed. That's why you're not sleeping. Is it? Or were you not sleeping for multiple nights and now you're very ill, right? So it's like, it goes both ways. It's like, we don't want to over pathologize somebody and we don't want to miss it. And we can't do that sitting in our ivory towers, right? We have to do that kind of on the ground at every level.
We talk about this being a rare thing, this postpartum psychosis, but at the same time, we talk about Lindsay kind of representing so many moms who are struggling and so many people who are just trying to do the right thing. She called so many people. She, raised her hand. She talked about her symptoms. Dr. Riddle, can you tell us a little bit about just, how the system should approach somebody like her? How do we interact with her? You have a baby, you might get like one check-in point at like 6 weeks. Like, how does the system interact with a Lindsay?
Yeah. So what you started with was postpartum psychosis is rare, right? But we're talking about 1 to 2 in 1,000 births. Like, it's rare, but not that rare, right? But we don't even have a DSM diagnosis for it. If we don't have a diagnosis, a structured diagnosis within our, quote unquote, Bible of diagnoses, how then can we go back in the system and say, let's look at everyone that had this diagnosis and how we treated them. Let's make sure it's part of training. Let's make sure it's covered by insurance. So, like, first and foremost, we don't even have this as a diagnosis. And yet you're right. At UNC, we see this diagnosis a lot, and yet we can't even capture it in the best way. So that is a problem just at like a foundational level, right? And Pam Bellick in the New York Times has been writing about this, and there's just been some publications on this to really try to define it, because we need those definitions to inform it. So what does a woman actually do, or what does the healthcare system do? You hope in cases like this, we're doing two things. We're scaring women tremendously. Okay, we're scaring pregnant women right now. We're scaring them that this is going to be them. We are scaring our patients with OCD all the time, because they are so scared that this could be them. Okay, so we're doing that one, which I want to be very careful with. But the other hope is that people are thinking about this now. And so that as they're going into their care, they're able to advocate to their OB, or they're able to advocate to seeing a therapist or seeing a psychiatrist early on, so that someone is monitoring them and that they're talking to their family about it, right? Anybody can call the PSA hotline, right? Anyone can call these hotlines. Anyone can look this stuff up, and anyone can go to the ER. But I think going back to Dr. Zink's point, like, sometimes I feel like people need to have a doctor in their family or a medical provider in their family to advocate for them, right? It's walking into the hospital with your sister and saying, she's not okay. I know she's telling you she's not suicidal. She's not okay. She is not safe. She's not showering. She's not taking care of herself. Words are words, but actions matter more. And she hasn't slept in a couple days, right? And so I think that that's sort of part of this also, is how do we get people to be able to use the right words and get that information to the right people? Because our system continues to eliminate a lot of the evaluators that would say, okay, you're saying you're not suicidal, but you're not looking like, but I know from my work that you're not okay.
Yeah, I was going to bring in Dr. Shapiro, and I'm just curious, like, to get your thoughts. We've talked here about a lot of insights into the way that we care for new mothers, and the caregivers surrounding them, and the ways in which the system is underfunded and we don't do enough. There's a whole different school of thought, out there, that this has nothing to do with the medical systems. This was an aberration. This is someone who killed her children. We're all struggling to make sense of it because it's so horrific. I'm just curious, like, on a human level, what do you make of these different conversations that everyone's having, trying to make sense of what happened here? Like, what do you see in this when you step back?
Yeah, so what I see here, I heard the word scared, and how folks can look at this case and feel scared that this could be them. What happened to Lindsay Clancy could happen to them too. And so I want to give my perspective from a medication standpoint, and why patients, might feel scared getting into a system like this, because I think more care isn't necessarily better. The reason folks might feel scared is that, first of all, we have inaccurate statements about psychiatric drugs coming from leading experts at, like, Harvard Medical School. We have huge variability in the diagnoses that are assigned to Lindsay Clancy, the same patient, the same DSM, with ranging from MDD with psychotic features to bipolar 2 disorder to postpartum anxiety. And so there's huge variability even within this diagnostic system. We have very poor communications between providers, where Lindsay at one point is prescribed Prozac after having such a horrific adverse reaction to the Zoloft. So even if a patient comes to a reputable psychiatrist, doesn't necessarily mean that the benefits of treatment will outweigh the risks. And that's one of, I think, a concern that I share with a lot of folks that are watching this case.
Dr. Riddle, I'd love to bring you into this. And also, look, the truth is, for those of us who don't have degrees in psychiatry, the question of medication is very complex. When we were asking some of our listeners before this episode, what was going through their minds, a lot of them were questioning, the cocktail of medications and what kind of impact that might have on somebody. But at the same time, imagining somebody with potentially her level of challenge going through it without medication also seems like not something I could personally imagine. So, Dr. Riddle, what is your thought on that?
Yeah, I want to be very careful with what we mean by treatment, right? Antihypertensives are a treatment, but if you give them to somebody with low blood pressure, they'll cause further low blood pressure. So treatment it's not as if everyone walks in and just gets treatment, right? And to be very clear on that, the wrong treatment for the wrong illness is a problem. So we have to start with the right diagnosis. And so I agree that if we give a treatment without close follow-up, or without, thinking through it or following closely, like, there may be side effects. And as I said before, psychiatry does not have an X-ray, right? It doesn't have a blood pressure cuff to say, oh, actually, this is high blood pressure or this is low blood pressure. Let's not give something that's going to make that worse. We are relying on a patient report. We are relying on a family report. And if a patient is saying, no, I'm just anxious, right, you can understand why you would then go with standard of care for anxiety. So again, I don't know every single detail in this case. I have not watched exactly what they've done, but SSRIs are not the treatment for everything. They're a treatment for the right diagnosis, right? Just as lithium, which is the gold standard of treatment, right? If you identify postpartum psychosis, it is one of our best treatments. It is by no means the treatment for an anxious patient, and patients are not often only one thing. The hardest cases we see, the hardest cases that I see often, are someone with very bad OCD. So what is OCD? Right? It's obsessions and compulsions. You can have a series of thoughts, right? So a woman, 100% of women will have intrusive thoughts after they give birth. A thought like, I'm going to drop my baby down the stairs, right? Doesn't become pathological because, only a small subset may say, okay, so I'm going to scoot my way down the stairs. Do they want to hurt their kids? Are they having images of throwing their kid down the stairs? They're having the image. They're not wanting to do it. So then they start avoiding it. In rare cases, right? And this is where it's really hard to distinguish. In rare cases, that woman's OCD will get so bad because OCD is associated with suicidality, right? It's not that it's just this anxiety disorder. It can get so bad that a woman loses insight. She stops realizing that these thoughts are not something she's comfortable with, right? But the gold standard of OCD treatment is an SSRI. So where do we start to, how can we just suddenly say, oh, well, should have been this, it should have been that, it should have been that?
Dr. Riddle, I've heard the phrase standard of care come up several times here. And I think when you talk about high blood pressure, I think we can all wrap around our head what standard of care is. In psychiatry, Dr. Shapiro, you even said, I think she got the standard of care. How can we say she got the standard of care? How do you establish what the standard of care is if we can't establish, and again, we don't want to talk about her case specifically, but what someone like Lindsay has? We can't even agree on her presentation, right? Is that because she saw too many providers? Is that because she didn't see enough providers? Like how does a field like psychiatry make a standard of care when it's so ambiguous sometimes?
Yeah, I promised myself when I went to med school I wasn't going to become a psychiatrist, and then I fell in love with the questions because, sorry, don't tell my parents, they know, but we've come back to it. It's hard. We don't understand the brain. I don't care what AI tells you. We don't have a full layout of how the brain works. Like, we don't get it. That's why we haven't been able to create, whatever we want to call it, the next sentient being, right? We don't fully understand all these things because the questions are still there. But if we back up, we're missing the diagnosis in the DSM. We're missing investment in sex as a biological variable. We're missing including women in research. And there was just a study out of Canada. 6% of all funding goes to women's health issues, not women's mental health issues, women's health issues. So I would love to have a blood test. And we have some genetic markers that point to postpartum depression and may start to point to postpartum psychosis, but they need to be bigger studies. So what if we could start to come up with biological markers that did tell us this person is high risk or this person is suffering from that? It's a huge problem in psychiatry. That doesn't mean we stop doing what we do, but it acknowledges a gigantic problem, right? These issues with postpartum psychosis being in the DSM, those were published well before Lindsay Clancy got into the media, okay? So we have been dealing with this issue for a while. We have people sitting in the American Psychiatric Association trying to get this training into residency training. I run a training for NPs and PAs and practicing physicians in reproductive psychiatry because you can't get it anywhere else. So we're trying, right? But how can we hold these standards when nobody else is within the system yet? It's a great question, and I hope we do better.
And I want to bring you in and have you chime in on this standards question. If I'm hearing Brian correctly, and Brian, tell me if I'm summarizing this adequately, you're in a position where you feel like, without knowing the intimacy and the intimate details of this case, you are seeing red flags in terms of the care. You said that she was given this, that was a red flag. There was miscommunication between or non-communication between different care providers. That was a red flag. I mean, Anne, talk about standard of care, but do you think it's fair to say we can call a spade and say, yeah, she got a lot of interactions with the medical system, but it didn't all go perfectly here?
Yeah, I mean, at the end of the day, there's 3 children who are dead. And so I think, yeah, things did not go well. And I think we can all agree on that. I think this question of standard of care is a really challenging one because ultimately it's what a jury of 12 people decide. And that's what the standard is of that day. And it depends who's on that jury, what that context is. I've even really struggled with the comment of like evidence-based care, because evidence for who and where and what. You hear Dr. Riddle talking about who an SSRI is right for. I work in Alaska. Like, what sort of care and access do we have at our hospital versus what she has in Boston? So that quote standard of care is really different in rural America versus is in urban America because of the access to resources. And I think what's hard for me in this case and so many others, and honestly, the way that our malpractice system is put together, is that individuals are held responsible for system failures, and that you can have people judging a quote standard of care who may not work or practice. They might be of the same specialty, but they may be practicing in a really different environment with a different set of resources and access. And so what I see increasingly is healthcare providers really becoming defensive in the way that they practice medicine. And I think that medicine was set up to be a calling. Our system was set up where it was a calling in which you put your time and effort, but the system isn't set up to support you as a healer and as a caller. 25-minute appointments is not a healing amount of time to connect with a patient. And so in so many ways, our system is asking people to do things that are impossible and to be held to a quote standard of care that is impossible. And both providers and patients are being let down in that process. 50% of healthcare workers, plus or minus, say that they're burnt out in one way or another. We see women physicians having almost twice the suicide rate as, people in the women in the general public as a whole. And so I think that the more that we other each other and other healthcare providers, and I see it in day-to-day interactions in the emergency department. I get it. Like, people are at their worst when I see them, right? Their kid can't breathe at 2:00 in the morning. That's awful. Like, their wife needs help and they can't get help. But if we continue to other the person instead of trying to find ways to fix the system, including malpractice cases, like I've wondered with this case, like, who is this benefiting? What is this helping? It's tragic watching the whole thing. What can we take from it? And how can we change the systems so that it's not all put on people, and that we're not, quote, judging the standard of care and what we're seeing on TV, but we're judging the system by allowing connection between providers and patients.
I know Mark's going to jump in, but it seems like a trial like this is a horrible vehicle to actually learn as a public as to what's going on in a certain medical field. It just seems like everything is torqued in a way to get a certain ruling from a jury, and it's not necessarily like the way that you would want to have this education moment with the public.
And also, just to jump in on that point, Anne, I love what you're saying about systems. And I think where my head gets scrambled in this case is look, she was a nurse at MGH. She was getting very responsive care. We can debate whether it was one medication versus another medication. It seems to me in some ways, it's like a systems conversation that's being sparked by the wrong case study. You know what I mean? And I wonder what you guys think about that, because one of the things we said going into this was a third of counties in the United States don't even have an OB. They don't have maternal care, but she did, right? So it's what are we actually talking about here? Julia, you have your hand up, and then I want to get Brian in.
Yeah, and the only thing I will say is this gives me the only word I can say is the ick of the true crime fascination, right? She stipulated that she did it. That's never been up for debate, yet they still had to go through this grueling process of describing it. For who? Who was that for? Why are we doing things like this? Why does this need to be 24-hour coverage? Because you know what makes me fear the most? I fear doing interviews like this, right? Because you feel like you're trying to get caught, to undermine things, to undermine the jury, to undermine the whole thing, right? That's not my job. I'm not a political pundit. I'm not a public personality. I'm a doctor, and I treat people and I do research. But you fear doing these interviews, but you know what's going to happen? Trial's going to end, and women's health is going to go linger back into an afterthought. So it's hard. You think about talking to the media and trying to explain this stuff, to try to introduce nuance, to try to introduce the urgency that we feel daily when we do our job. And yet it feels like it's for a kind of a true crime punchy attention grab, when really what we need is actually more humble care, just like Dr. Zink was talking about.
We appreciate you coming on and at least trying to do this nuance. And we've talked about on our show just about being humble about what we're good at, what we're not good at. I think that one thing that I'm kind of struggling with at this moment is because the stakes are so high is how do we honestly talk about the shortcomings of our psychiatric care system. We've talked about them. I don't even want to repeat them, without inadvertently sending women a message that, look, the system isn't that good. It's not reliable. In fact, it might be dangerous. So like, don't get help. I need Dr. Riddle or Dr. Zink or Dr. Shapiro, one of you, to tell us, like, do you want women to speak up? Are there enough resources that we can catch these things with, even if it's not perfect, with a safety net system? Like, how do we be careful and responsible that our critiques and, us sitting here talking about this doesn't like undermine, our show is about trust, undermine the very trust that is required to make an intervention possible?
Brian, let's go to you first.
Yeah, I think what makes patients mistrustful of the system is when we feel the system is not being honest about their shortcomings. When they're being a little bit overzealous, or they're claiming that they are more confident in their treatments than what they should be. And so I think that's the concern, and I think that was elicited around the COVID times. And I think this case is a reflection of that as well, and that's relevant to your question.
So you feel like there's been a circling, like a defense of the industry, of the medical profession, of the field. Like, just explain that more? What are you seeing in this moment?
What I'm seeing in this moment is, there's this concept that these psychiatric institutions are, authorities, that they have the answers, and that there's this unique, they have this specialized, this unique information and knowledge that can help them. And so I think there are many instances in the history of psychiatry where psychiatry has been actually a net harm in several respects and has led to several issues with regards to treatment and mental health. That I think if psychiatry as an institution were a little bit more open about their shortcomings, but also acknowledging their strengths and how they can truly help people, the most vulnerable people, especially those, including those in the postpartum period, then I think that's a framework that'll actually make patients potentially feel more comfortable, because they feel like they're dealing with like a real kind of entity that has flaws, but also has a lot to offer.
Dr. Riddle or Dr. Zink, I want one of you guys to just weigh in. Speak to moms. Speak to moms who are listening. Can they trust the system, albeit imperfect, that we have now?
Let's go to Anne first.
Yeah, I would say moms, yes, I think that it is an imperfect system. Medicine is an art and not a science, but there are hundreds of thousands of healthcare workers working in a system that's imperfect, but are there for you and are willing and able to go to bat in all sorts of ways to be able to be there today. I think that suffering in silence is the worst thing that anyone can do. And so I think ask for help. And that might be from a provider, that may be from your loved one, that might be from your parents, that might be from your spouse, it might be from your neighbor. It may be someone totally separate and different. 2, know that the system is imperfect. And so you and your family members may be the only interoperability within that system. And so you might need to connect and say, I went to this provider. These are the meds. As Dr. Riddle said, bring an advocate with you to help you navigate it. Data shows that when you come to the emergency department, people remember 10% of what we told you. So you're not going to remember what was said. That's okay. Ask if you can take notes. Ask if you can record it. Take the information down. Ask for it to be printed out. 3, keep records. Know what you were given. Know how you're feeling. It isn't just medication, as Dr. Shapiro said, but it's also what's happening, the waxing and waning systems. We brought up hypertension as this example of like, we know what's happening in the emergency department. Like, it drives us nuts that people come in for hypertension and when people are hurt or scared, their blood pressure always goes up. So we never treat you usually for high blood pressure in the emergency department because we're only seeing you this one small bit of time. So even that has like tons of nuance to it. But knowing what people's blood pressure happens over time makes a huge difference. I always tell people, I'm seeing you in this tiny little glimpse of time, but your health is so much broader than that. So bring with you the information of this larger context of what you're experiencing so that we can take the knowledge and science and information that we have, the best of it, and be able to sit side by side with you to figure out what that next best step might be. Might be medication. It might not be medication. It might be hospitalization, but we can only do that like in combination and in partnership with you. And then Dr. Shapiro said, like, know that it's imperfect. and it's going to be imperfect, but don't give up just because it doesn't happen once. You know, there's a joke in the emergency department that if you come in 3 times, even if you're the pizza delivery, we'll admit you at that time. Because like sometimes we just don't know. Time is a better diagnostic test than any one thing we can do. And that's particularly true for things like psychiatric disorders. And so time gives us so much more insight. And so if it doesn't work out the first time, don't give up. Show up again and again and again for your family and friends. And the last thing I would just want to say is like to family and friends, be there. Don't let women do this on their own. Show up with them in the emergency department, show up with them at their appointments, check on them, bring food, let them sleep, do these things to help them. This takes all of us in so many ways. You know, in preparation for this, I ended up reaching out to like 3 friends who had recently had kids who were totally fine. But I was just like, you know, I need to walk the walk and check on you and make sure that you're doing okay. So I think we can all do that today.
Dr. Riddle?
Yeah, I'll marry the two, I think, which is that 2 parts. One, I actually think, look, postpartum depression affects 10 to 15% of all women, right? One of the leading complications of childbirth. I actually think we've done a tremendous job in having that conversation in the last 20 years in ways we haven't in years past. I have so many women from prior generations reach out and say, I'm so glad someone's finally talking about this. I know I suffered, but I couldn't bring it up. Right? That women used to get dropped off at sanatoriums because like they were sort of told they weren't normal and off they went. It wasn't acknowledged that this may be a side effect, right, of having a child, of which there is good treatment. And the other thing I will reflect on is we get women better from postpartum psychosis all the time, right? These are treatable illnesses, but you do have to be with a provider that you trust. So it goes both ways. The system has so many good people. People are just looking for the right answers, right? But if you're with someone that you don't trust or it doesn't quite feel right, you have a right as a patient to find someone else to take care of you. In lower resourced areas, that's really difficult. And I do want to acknowledge that. But I think that it goes both ways. I say to a patient at the end of every intake I do with them, do you feel comfortable continuing with me? Because what's most important in psychiatry is that you feel comfortable telling me what's going on, because otherwise I can't do my job. And so I tell every patient when they go to see a therapist, give it 2 to 3 tries. And if it's not working, it's not the therapist for you. Because you can't force a therapeutic relationship where one does not exist. And I think patients have to take stake in that as well. And so I want to almost bridge those two, right? There are weaknesses. There's weaknesses in every system. And you as a patient are allowed to say, this one doesn't work for me. Because we rely on you actually being upfront with us and answering our questions, because that's the best test we have right now. It's inappropriate. It's not enough. We need better, but it's you're talking to us and it's our observations with you and it's collateral from family. So if you're going to see a psychiatrist or you're going to see a therapist, ask your partner if they're okay. At the top of every note I have the person I call in case of an emergency and their phone number and that I've gotten approval. You can ask that person in your life to write down what you want them to share with the psychiatrist, right? So there are these little things that we can do to partner to help in a very imperfect system without biomarkers, which we need, right? And I believe in, and I believe we will get there, but we need them. We don't have them yet, that it is reliant on these other pieces. And I think that we can all help, just as Anne was saying, just as Brian was saying, that we can help to bring these things together now, rather than hoping that your psychiatrist or your therapist is a mind reader. The other thing I will note is that we just did a wonderful study both out of Toronto and out of UNC that showed that therapy delivered with good supervision from a therapist, but even by doulas and nurses, can prevent and treat postpartum depression, right? So there are all these creative ways that we're trying to reach more people. And I have a lot of hope that as we have these conversations and destigmatize this time, that people are getting better and they're reaching out and they're doing things, whether that's at the community level with their doctor or beyond.
Dr. Riddle, when you're talking about biomarkers, are you talking about like science fiction stuff, or is this like for real for us?
There's some genetic work. So Jen Payne and Jamie McGuire have done some excellent work looking at biomarkers. Again, in some ways, I'm particularly talking about postpartum depression. Postpartum psychosis, for all the reasons we've discussed, is epidemiologically very hard to study at the moment, right? Because we can't go back and scoop this in the same way that we hope to. Though we are working very hard at that to get cohorts big enough. At UNC, there's a mom gene study. So taking all women with postpartum depression and looking at their GWAS, so looking at the genetics to say, can we start to get some predictive biomarkers? So it's, and by what do biomarkers mean? I don't mean like, we try with the wearables give us general stuff, but we're really talking about like in the direction that Alzheimer's has gone. Can we start to identify things in the blood that say, regardless of dementia, you may have the disease, right? You may be someone who's highly at risk of this in the postpartum. Right now, we do that with a really robust reproductive history, right? Did your mom have a lot of trouble with reproductive transitions? Did you have trouble during your menstrual cycles, right? Did anyone in your family ever have hormonal sensitivities, right? Thinking, one etiological thinking being it's this massive hormone transition that happens in pregnancy into the postpartum.
Like, is there, I know you talked about the advances in postpartum depression and we talked about psychosis being different. And I think we need to remind our general audience that these are very different,
Very
conditions. But are we doing an okay job, lousy job, good job at like asking the 5 questions for a woman who's about to deliver to screen? Do we have a screening tool for just the psychosis part? I know we have screening tools for the depression part. Do we have a screening tool like these 5 questions for psychosis?
We don't. And the one thing I will tell you that's to make it very hard, right? Self-report is really difficult because self-report is reliant on insight and a person's trust that they will tell you the answers. Okay, so we don't have a particular, but we don't have great ones for psychotic illness generally, because part and parcel for many psychotic illnesses is paranoia, right? Paranoia that you cannot trust the other people in your world. So very common psychotic symptom in postpartum psychosis is an altruistic thought that the world is not safe, and therefore you have to do something in particular to keep your baby and yourself safe from an unsafe world. So if a doctor asks you, are you having thoughts of harming your baby? You're not going to tell him. You're not going to tell him even if you're not psychotic, because what if they call CPS? These are really hard and nuanced things to write down on a piece of paper, right? There is evidence that certain marginalized populations won't fill out that harm to child, even if it's there, because then it's a written document that then could be reported on their behalf, right? So I talked about those intrusive thoughts, normal, right? I had them after my kids. Didn't mean I wanted to hurt my kids, but if I had written down, did I have the thought without any nuance? Very scary. So these are really scary kind of and nuanced topics to talk about. So no, we don't have those. We don't have a standard written screener. I'm trying to kind of provide context for why that is. In a psychiatric ER, if you go to the ER because something's wrong, there are these questions that are asked, right? You're hearing voices, are you seeing any visions, all those things. But they require you sitting there and watching the person, right? Are they going like this? Are they looking away and looking around the room while they're talking to you? Or are they just like, no. So it also requires really good observation on behalf of the clinician. We often talk in postpartum psychosis about a look in their eyes, right? There's something you feel it's not right. How do I explain that over the phone to somebody, right? So it's hard. It's so hard.
Yeah. I want to ask, and maybe I'll start with you, Anne, about this. I wonder if part of this is also making postpartum care just sort of the standard and not just making it about the 10 to 15% who kind of suffer from postpartum depression or anxiety. Because I was reading somewhere, and again, I know that we always roll our eyes when we bring up Scandinavia as an example, but I can't help but notice that, I read somewhere that in Iceland, they have something like between 7 to 11 postpartum care visits from either, midwives or public health professionals or something like that, right? That this idea that, you need to wait till something's really wrong and then you have to know to go to a doctor. That when I know when my first kid was born, and I've been transparent about this, I went through sort of a very crippling postpartum anxiety. And I don't know that anyone really knew that, or even knew to ask, and until it got sort of really bad. And I was really panicked about taking medication for it because I didn't want it to interfere with breast milk or whatnot, right? Like all the things. You guys have heard this. I just wonder if, like, as not just doctors, but as a society, do we just need to, okay, you just gave birth. That is like an insane thing to happen in a person's life. It's, yes, absolutely beautiful. This idea that we're like natural moms at birth. No, I like sucked at being a mom the first few months. I didn't know what I was doing. I was terrified, right? And so I just wonder, Anne, does some of this just have to do with, like as a society, like I almost hate to put this only on doctors. You know what I mean?
Yeah, totally, Dean. I mean, short answer is yes, 100%. We need way more there. I mean, I think breaking it down into a couple different buckets, we talked earlier about screening. Even the suicide screening has really poor evidence for it from the emergency department and for others. And so, like, not only do we have no screening essentially for postpartum psychosis, but we have like no real good evidence, even when someone comes into the ER saying that they're suicidal or homicidal, to be able to move forward. I think too, Mark, you asked earlier about like, what is the system? We don't have a system of healthcare. We have a lot of different types of system. And in some ways, in this case, with her having private insurance, she was actually almost out of the system more. Like she had more access to care, but there's less incentives within private insurance to do care coordination, to do follow-up. So actually, as she was sick, and the Massachusetts was working on an entire Medicaid waiver to do better postpartum and post-discharge care for Medicaid patients. But that isn't going to affect her in private insurance. She also went between Rhode Island and Massachusetts. So again, you've got different states and different state systems within care. So I think that is there. And then, you've talked a lot about on this show about, public health and public health systems. Oftentimes they're overseeing these Title X grants and Title V and the ways that they're getting out money and things like teachers, nurses who go to homes to check on people who are not doing well. But our healthcare system, particularly within the private insurance, people rotate in and out of private insurance, particularly as we've moved more to a gig economy so quickly that there isn't an incentive to be able to do longer care to look at the whole benefit of that patient in the system. So I actually think private insurance is less incentivized to think about care coordination. It is very incentivized to think about payment. So the payers in this case all knew which meds she had, knew all of her visits, but the providers don't for so many reasons. We've set up our system as a payer system instead of a provider and a care system. And there is where you see like public health and other things trying to fill in these gaps. So I think we do need to think about the different systems. In Medicaid, for example, every single state changed from just providing Medicaid after a baby is delivered for that first month to 3 months to 1 year. Once there was a waiver from the federal government saying you don't have to prove to us that this is beneficial, we'll go ahead and let you do that from a Medicaid section. State of Alaska, it takes between $1 and $4 million to do a waiver to our Medicaid. So if we want to change like one little thing, it's a huge lift to be able to change it. And so that was an example where we saw the federal government saying we need to do better for postpartum care to allow mom and baby to stay insured for 1 year. So how can we lean into that and insurance and other mechanisms to provide better care for moms and babies through that transition? Well, we oftentimes talk about the fourth trimester, that, 3 months to a year after delivery, where there are a lot of hormonal changes, there's a lot of life changes, and being able to support that dyad of that mom and baby.
Brian, what do you make of this?
Yeah, and those systems issues are very important. There's screening that's essential, but also early detection. And I wonder what it would be like when symptoms are mild to have a relationship with a psychiatric clinician where you have a point of contact, where family knows to reach out to them, where with consent, and the patient knows to reach out to them. So you have that in place, and going to a psychiatrist, and what would it be like to go there and not even be assigned a diagnosis yet, to not start on the first visit get a pill, to build a relationship, to get to know a patient's baseline, so you can clearly see when things are going in the wrong direction. At which point you might have that opportunity to treat them in a timely way.
Yeah.
No, that's so, Brian, we call those preconception consultations, and we do them. And to be very clear, the ethos of reproductive psychiatry is the fewest or no medications at the least effective dose. So actually, our goal is really to just talk to patients about the risks of untreated illness, which are real, versus the risks of treatment, whatever it may be, right? I wean a lot of medications for patients, right? A lot of patients come to me on a lot of meds and we say, hey, let's try without these. Because if we don't know, we don't have an N of hundreds of you on these medications. So that's a big part of actually what we do. And therapy is a standard of care for mild to moderate depression and anxiety. So again, sorry to use the standard of care comment. We can only do what you have to defend these terms sometimes. And I agree that they're sort of unhelpful at different moments. The other two models that have some evidence and I think we need to expand on are collaborative care, right? Which is an integrated psychiatrist into OB care, right? So this person is getting multiple visits during pregnancy. And then, right, if there's a mood concern, they get a 2-week check. And if not, then they get the 6-week, You can go back to, intimacy kind of check at 6 weeks. But what if we had more integrated care so that there was psychiatry is a field that is deeply, deeply under-resourced, right? There are not enough of us to do the job. So everyone actually can't see a psychiatrist. So then we have to expand to NPs, we have to expand to PAs, we have to expand to other folks within the system that can help us. But what if we had more collaborative care models where a psychiatrist is on the team and can sort of look over the whole thing to help figure out who's in there? And the other one is the pediatricians, right? And how can we better, and the ERs, but how can we better fortify where those moms and families are going, which is multiple times to a pediatrician? It's not on the pediatrician, that's not their patient. But how could we use the existing infrastructure to better support these things, right? To better provide care where parents are going while they're dealing with all of those things, breastfeeding issues, not sleeping, trying to go back to work, trying to fill out their FMLA paperwork because they just want to extend because their child needs extra care, all these things, right? How can we meet them where they are? Because the OB funding model, the only other thing I'll add is there's some interesting OB funding models trying to address this. One is called Compass. It was out of Northwestern, and now I think they've taken it over to Brown. People are trying to think about this stuff, right? We don't have it figured out, but we keep trying. That's all I can say.
Yeah, and I love the idea of that collaborative care comment that Dr. Riddle mentioned, is having a psychiatrist in there in the trenches with the primary care physician, pediatrician, et cetera, to provide consultation is essential. I think some of the standard of care of psychiatry needs to change with regards to treatment during pregnancy, like for instance with SSRIs, where very often in the risk-benefit calculus in the informed consent process, we weigh the risks of ongoing treatment to mom and baby with the risks of untreated depression. But very often that can be a false dichotomy because the studies upon which those recommendations were based, patients were essentially pulled off of their antidepressant and obviously felt way worse. And it was interpreted as a relapse of their underlying condition. I think there are alternative ways to treat depression other than medication that might warrant a gradual taper of the medications, even when they're in that pregnancy period.
Yeah, Brian, I'll just push back on that because that's not what the research shows, actually. There might be one or two studies, but what ended up happening historically was they compared risks of women with no mental illness to women with mental illness on these medications and called the women exposed to this, not comparing it to disease. Actually, that's where they called it a risk. So I do want to gently push back on that because I think that's a misrepresentation of the whole body of literature, particularly recently. So I do think that's probably a further discussion to be had, but I don't want to leave patients thinking that one bit of data you talked about is actually the whole body.
Okay. And want to finish with you. It seems to be the case that we've not seen a tragic story like this since Andrea Yates, which was 25 years ago. And if folks aren't familiar with that story, that was a mom that drowned her 5 children. And at that point, postpartum psychosis, I think it's fair to say, was not something the public was really aware about, and I think became aware of it through that trial and through the retrial where she was actually found not guilty because of psychosis. I want to ask you if you're optimistic or pessimistic right now, all these years later, 2 decades later, that coming out of this tragedy, more will be done for maternal mental health. And I would just seed the question by saying, like, back then, we didn't really have social media. So there weren't 1,000 people with 1,000 different takes at every millisecond. Back then, I don't think we were obsessed with true crime, which I think for many people, they're just sort of missing the point of what could be a constructive conversation coming out of this case. But today, we do see groups that are rallying on behalf of maternal mental health, around this case. So I just want to know, are you optimistic that something positive may come out of this, or do you feel maybe more in the camp that we're just not capable of having a national conversation that would be productive at this point?
Yeah, I think I'm an eternal optimist. I say patients are my why and policy is my how. And I think that we have seen huge changes and will continue to see huge changes. But I've always felt that to have any real meaningful change in health and health policy, you have to have 5 major things. You need to have providers, and we've been having a lot of that conversation. You need patients, and we're talking about what that looks like. We need policymakers, and we need change to see in there. But I think you also need the press and you need the public. I think that you need conversations like this. I think you need to have community conversation, because that honestly is what drives the pressure to make policy changes as a whole. I also think that the more we know, and the better we do. Like, I've loved this conversation and seeing like Dr. Shapiro and Dr. Riddle and seeing the nuances in the ways that medicine is thought about. I, as an ER doctor, I'm like, peace out. Like, I don't know. Help me help the patient at the end of the day. But medicine is so much more of an art than a science. And so we need, just as Dr. Shapiro said, transparency and honesty, as Dr. Riddle was saying, to find that connection to patients to be able to move forward. So I'm excited for this conversation because I want to see more for moms. I want to see more for families. And I think at the end of the day, I think back to like the NUCA model out of South Central Alaska, where patients aren't seen as moms and babies. They are seen as an entire family unit for every one of their checkups, because that is the family unit that we as healthcare can support so they can do better. And I think these aren't systems. A friend of mine's like at the International Space Station right now. And I keep thinking about him looking down on us, and he can't see Medicaid versus Medicare versus mom versus baby, right? Like, he just sees this big, beautiful earth with people trying their best in the system to do better. And so I think by focusing on patients and finding policies to support them. And so I'm grateful for this conversation. I'm grateful for people interacting and finding ways, either checking on a friend or creating policy changes as a whole, so that we don't have this in the news and the media. But I also, as providers, and I'm sure Dr. Shapiro and Dr. Riddle will agree with this, we see these tragic stories every single day in our care in different ways in where they're falling. So I don't think we need to wait for another case to do better and to do more.
And that is really, really well put. And I'll just say that, you know, I think you all have helped us answer the question about whether the Lindsay Clancy trial is the sort of right case to be using to talk about the deficiencies in our system. And I guess I would say there's been this one kind of productive part of the trial that it's actually is leading to some of these conversations. And I will just say to our listeners that Dr. Shapiro and Dr. Riddle are continuing in the chat about some of the things that they think about the studies, which I also think is really, I think, important for our listeners to know that, like, these are conversations that are taking place amongst practitioners as well. So I just want to thank Dr. Julia Riddle, Dr. Brian Shapiro, and Dr. Ann Zink for joining us today for this conversation on Why Should I Trust You?
Thank you.
So that was our podcast for this week. Please leave us questions, comments to questions@whyshoulditrustyou.net. I am Brinda Adhikari. He is Tom Johnson. He is Dr. Mark Abdelmalek, and she is Maggie Bartlett. Please leave us a rate, subscribe to our Substack. And again, we will be putting those resources that Mark mentioned. If you are looking for some resources, and if you're seeking help, you'll be able to find those numbers in our show notes. And thank you so much, and we'll see you right back here next week.